Hi, everybody. It's Dr. Kerry Reller, your family medicine and obesity medicine board certified physician in Clearwater and Palm Harbor, Florida. I wanted to come on today to talk to you about a question I get a lot in the office when I do annual lab work or even biannual lab work. And that is about the labs that we check on for your kidneys. So I'm going to start a presentation about chronic kidney disease. So why am I checking your kidney labs? So patients with chronic kidney disease. Chronic kidney disease is a high risk for end-stage kidney disease when you have to go on dialysis so that the procedure of dialysis filtrates your kidneys to get rid of all the toxins and everything that your kidney would normally do. It's also a high risk of cardiovascular disease and death. Chronic kidney disease affects 47 million people in the US. That's about 14.8% of the US adult population. And because of dialysis and other things, it creates excessive healthcare costs and also morbidity and mortality. Another thing about chronic kidney disease is that it's a silent kind of disease, and it can silently progress to advanced stages without the patient even knowing. So therefore, we would do early detection and screening so that we can intervene earlier on and not have to proceed all the way to dialysis. So risk factors for kidney disease, the biggest ones are bolded that I see most often, and that's type 2 diabetes or longstanding type 1, longstanding hypertension or high blood pressure, peripheral vascular disease, cardiovascular disease, or cerebrovascular disease. So that's, thickening of the arteries and everything that can be due to high cholesterol as well as smoking. Prior or recurrent severe acute kidney injury. So severe dehydration that may put you in the hospital can cause acute kidney injury, and that recurring several times could lead to chronic kidney injury. Today, we're only really talking about chronic kidney disease, though. Obesity is also a risk factor for kidney disease, as well as heart failure or liver failure. And autoimmune disorders like lupus is the biggest one I can think of right now, can affect the kidneys. And then drug toxicity. So, for example, I had a patient who came to me, she's probably in her 50s or 60s, and she had longstanding high blood pressure. She was a smoker. She had high cholesterol. She was also had obesity. Well, she also had chronic headaches, and she was taking lots and lots of over-the-counter analgesics. And one of the ones she was taking was Goody's headache powder. And I'm not too familiar with it, but when I looked it up, yes, it contains lots of aspirin and caffeine, which in combination of overuse can hurt your kidneys. So she is definitely, when we looked at her kidney labs, she had some elevated markers that we're going to discuss in a second. Other common drugs is lithium, that's used for bipolar disorder. Other cancer drugs are toxic to the kidneys as well. So really getting a good history from our patients is very important. So the blood test that we do, the focus that we do for the kidneys is something called creatinine, a blood urea nitrogen or a BUN, and an estimated GFR, or glomerular filtration rate. So that kind of determines how well the kidneys are filtering out those macromolecules or big particles. We typically do those on a complete or comprehensive metabolic panel. If you look at your order sheet, that's what it would be under. It's also on a basic metabolic panel. The other things we look at are urine tests. So we're looking for protein in the urine, and that can be called albuminuria or proteinuria. We're looking for a special ratio related to the creatinine and determining if it's elevated or not. There's also such thing as a spot urine protein test. Even one of the pharmaceutical companies that uses medicine to protect the kidneys is giving them out kind of for free to be able to detect this even sooner. Basically, the urine tests show that the kidney isn't filtering out those big molecules that can occur in like primary kidney disease, or like I was mentioning with lupus, a more systemic widespread disease. And those risk factors, those big ones again, would be high blood pressure, diabetes, high cholesterol, smoking, obesity, etc. So chronic kidney disease is actually defined by the presence of kidney damage or decreased kidney function for 3 or more months. So one-time testing and finding that your lab markers are abnormal isn't sufficient. We actually have to repeat that in 3 months, maybe even again, to determine whether it is true, chronic kidney disease. So one of those, like I said, was the GFR. That's if it's less than 60. A lot of labs read it as normal if it's greater than 60. Really, I'll get to that in a second, but we'll check out the stages of the GFR. So and then also kidney damage could be is one of the criteria. So that can be defined by structural abnormalities. So that can be on imaging, such as an ultrasound or a CT scan, or even from biopsy for pathology. And then, like I was mentioning before, those functional abnormalities other than the GFR, like the protein in the urine, or even from a normal urinalysis that showed some urinary sediment. So the stages of chronic kidney disease are based on that estimated GFR. So normal is actually considered 90 and above. Mild is 60 to 89. Stage 3A is 45 to 59. I find a lot of patients with high blood pressure and diabetes live in this one. And stage 3B, 30 to 44. And then stage 4 is severe, 15 to 29. And that's when I start thinking about getting a kidney doctor on board or a nephrologist. And then end-stage kidney disease may be when they're under care of nephrologists and possibly even getting dialysis. So this is a good example of why we monitor it over time. So this is a trend of the serum creatinine that goes up and down. So basically a real increase of creatinine, like you might see here, could be due to like an acute injury, but on top of chronic kidney injury, right? Because normal creatinine, I like it kind of below 1. So we already know that this patient's creatinine is above normal, and then it's trending up and down. So it's really important to have a good idea of what is going on over time with the serum creatinine. That's why I keep making everybody get their lab work, about twice a year for to check on their kidneys if they have high blood pressure or high diabetes. And then the CKD stages based on that albumin to creatinine ratio. So ACR is albumin to creatinine ratio. So less than 30 is actually, normal or stage A1. But then you get into that moderate where it's 30 to 299 milligrams. That's A2. And then the greater than 300 is A3. So how do we actually treat these? So if we're starting to see over time, right, if it's multiple instances of the elevated creatinine, elevated BUN, low GFR, or elevated albumin in the urine, we start to pay attention, and then we want to put on a certain medicine, whether you have high blood pressure or diabetes or not. And that is something like lisinopril, losartan, any of those ACE inhibitors or ARBs. We use those to protect the kidneys. And typically anybody diagnosed with diabetes should be on one of those, whether they have high blood pressure or not. And if you have high blood pressure, obviously you might be on a higher dose, but if you don't and you have diabetes, maybe you're on a very low baby dose of it to protect the kidneys, as long as you're not getting like hypotensive at the same time. And then if, it's still not controlled after being on that ACE or ARB after some time, there's a new class of medications that are actually diabetes medications called SGLT2s, like Farxiga, Jardiance, and they can be used also to help, not progress kidney disease any further. So we typically use those too. So these are my references. And if you have any questions, please reach out at our website, Instagram, Facebook, and make an appointment if you have any other needs to follow up and have questions on your particular labs. Okay. Happy to see you and hope to see you next week. Thanks. Bye.